So, ladies, thank you so much for coming to speak with me today. So, Kim, please tell me a little bit about yourself and what exactly it is that you do with Affinity.
So I started in hospice probably about 12 years ago. My background for that was I was in counseling, and then there was a need for a bereavement coordinator slash grief counselor at Riverside Hospice, and they asked me to come over and do that. So when someone goes on hospice care, it's not just the nurse, it's a whole team. So with that team, you have the nurse, we have personal care aides, social worker. The family also has access to bereavement, to a grief counselor, and then as well as a chaplain if that's what they need. So it's a whole team. So that's how I actually got into into the hospice space. But while I was recruited from the VP of Riverside Hospital to come and do that. So that's how I landed there.
Okay, and what about you, Chrissy, as a medical social worker?
I've been in the social work related field for about 10 years now, with about three and a half of those being in hospice. And it took me a while to figure out, but it is my passion. Really, what I love the most about it is it really focuses on providing like a roundabout interdisciplinary approach, very holistic. And my role primarily is to deal with all the psychosocial needs. So, assessing the families and the patient's needs, whether it's for end of life care planning, if they're needing education, emotional support, and connecting them with resources as well to help them with processing everything that's going on. Because a lot of times, what ends up happening is whether or not the individual has been sick for a while now, or this is something that's suddenly come on, there's a lot of anticipatory grief on, how did we get here? What is happening? Where are we going to end up? And how are we going to manage this once our loved one is gone? So I kind of help them with navigating those different things. A lot of times they don't need me immediately. So I kind of like to meet my families where they're at and make sure that they have my information. So when the time does come, I can step in and say, okay, these are your options. What would you guys like to do? So, yeah.
So, how did the word hospice come to be? Because I know it sounds a lot like hospital. Does anybody know? Do you know how that term came about?
Actually, good question.
I wonder why they use that word. I think it would have something to do with healing. So besides the hospice, we also do palliative.
Hmm.
And I know when you and I spoke, Candace, like there's a misconception out there that and it goes with a lot of providers themselves. They think palliative is hospice and hospice is palliative, and they just use that as all encompassing. Just you need to go home and you need to be on palliative. So what does that look like? And that's kind of my role. I come in and I'm like the educator. I come in and I go to hospitals. Like I spent a lot of time yesterday at a hospital in the ICU and the MICU, just kind of helping the physicians understand like what palliative means and hospice means. So I'm constantly out. That's my role.
Right.
So there, the umbrella with the whole care. So palliative is, in a nutshell, you have like 16 months or less. You've been given a life limiting diagnosis, whatever that looks like. And it's been life limiting and it's not hard and fast, but it's usually 16 months or less. And then, so what our palliative nurse practitioner does, she works very closely with the other providers. So someone that may have a oncologist, a nephrologist, she kind of gets all of those providers on one page as far as the medications go. So you're not having like the polypharma. And it's kind of nice because they spend a lot more time with the patient than say the specialist does. And that's when they call us in, the specialists call us in for those types of cases. Because instead of the patient having to go to 15 different appointments, they kind of narrow it down. And then it also kind of starts having that conversation about end of life and what it looks like. And then that's where the social worker, Crissy, would come in and just kind of, we start preparing them and we start giving them the tools that they need, that they don't even know that they need. And then when it comes time to start talking about the next step, and we don't say that, the next step is you got 6 months or less. We call it the highest level of health care that you can possibly get in your home for free. And it's covered, the majority of our patients are Medicare, like that age. So it's covered under Medicare. We do have some patients that are younger, and just sometimes they may not have the hospice benefit, but we work with that. It's not hard and fast. And the insurance companies are good about working with us too. But by that point, when it's time for the hospice, that's when the team comes in. Because up until then, they're kind of still navigating. And then when it's time to go that next step, which is very difficult, that's when we have our team. We kind of like merge on them and start really helping them just figure things out. Sometimes Crissy will be with them just to kind of talk about funeral arrangements, whatever they want to talk about. It's hard for people to talk about it.
It is hard. So I remember when my mother declined suddenly, my sister was taking her from one appointment to the other, one hospital to the other, and then rehab. I had to fly to Georgia from Washington to help my sister. And my mother had gone from the hospital, she had gone into rehab and assisted living, and then back to the hospital. There was a point where nothing more could be done for her. Then it was determined that she ought to go into hospice. And I just remember nurses taking care of her. And even before going to hospice, working with the hospital team, which I know you know about. So was it nurses, doctors, and maybe you can just fill in a little more for those who don't know the process.
So like that's what your mom's a perfect example of, had you guys known and also had the physicians or even the rehab facility been a little bit more educated on what hospice looks like, that it could have prevented a lot of that going back and forth from the hospital to rehab to this back and forth. Because when you get to that point, you're just kind of sustaining the patient, and it's not about quality, it's about quantity. So we're all about the quality. So your mom could have come home probably 6 months sooner and had us come in, and she wouldn't have had to keep going to the hospital, going to rehab. It's kind of like we come to you, the hospital comes to you. Does that make sense?
Mm-hmm. Yes.
And as far as the process goes, I can just the background would be like, so perfect case with your mom. You guys are kind of at, well, what do we do? Does she go back to the hospital? Does she go to rehab? What does she do? You would reach out and call someone that handles palliative or hospice. If I get a call today and you say, hey, my mom, I think we need help. What can you do to help us? Then my job as the community liaison is to get the information from you, find out what your wants are, right? Do you want her to be home? Do you want her comfortable? What does that look like? And then I paint that picture. I let you know what we can do under the hospice. The hospice benefit is a benefit that people just don't know about. It's a little blurb under Medicare along with long-term care, and it says hospice benefit. People look at that like, oh, that's when I'm, on my deathbed and I've got a week. That's not the case. And if they knew about it, I guarantee you more people would take advantage of it because it's 100% covered. So say you call and you're like, hey, my mom, this is what's going on. It's a vicious cycle. She's going back and forth, back and forth. She's been diagnosed with COPD. She keeps having exacerbations. It's a cycle. Well, then that's when I would ask, let me get the medical records. This is what we can do. If you want your mother to stay home and be comfortable, not have to go back to the hospital, not have to go back to her doctors, she just wants quality versus quantity of life, then this is what we can do for you. We can get you all the medical supplies, all the medical equipment. We can have a nurse come out. We can have a personal aide, which attends to the ADLs like bathing, washing, things like that. Also, any supplies, and that's a big expense. That's all covered. All of our nurses, all hospice nurses are they're all trained in wound care. So instead of having, say, home health come out and a wound care nurse, it would just be hospice, our team. And then for any, like we're saying, the social work side of things, because in your case, you're like, what do I do? I'm getting this from this doctor, this from that doctor, all this paperwork. I'm not sure what to do. What insurance, what does she have long-term care insurance? Does she have this? That's where Crissy comes in. And so it's a whole team, and it really takes a huge burden off of the family. And it gives you guys time to be with your mom or to be with your loved one. Let us take care of them, gives you a break. Another thing that they implemented in the hospice benefit, which I don't think we had talked about, it's called respite. So respite it's not for the patient, it's for the caregivers. So they're allowed, it's 5 days every benefit period. And that's insurance. So you start out with the 90 days and you go 60. But that gives the caregiver a break. And if you guys need to go, I don't know, you want to just go away for a couple of days. We take care of making sure that your loved one is in a facility, and then we pay for that and we take care of the patient while they're in there. It's a wonderful thing. And some of the caregivers, what they do is they just stay home for 5 days. They, just to have a break. And that's covered. I mean, that's 100% covered. And then we have patients, families that are like, well, what do I do? We got a wedding coming up. You've got respite.
Right.
Also, we have volunteers. That's all covered too. So, say you have a standing doctor's appointment, I don't know, every 6 weeks or something, or you have a standing appointment. We have volunteers, and Crissy gets with the volunteer coordinator, and we have a volunteer come and sit with your mom, come and sit with the patient. They don't, they can't do anything medical, but they can be there. So you can go out and maybe every couple of weeks you need to go grocery shopping, whatever that looks like. We have the volunteers too. So it's wonderful.
So, Chrissy, what might a typical day for you look like? I know that Kim touched on this a little bit. Is there a typical day?
So a typical day for me, it just kind of varies. I typically take it one day at a time because we have patients that are with us for terminal illness. We can't do a lot of long-term planning. And so I kind of go in the morning, look to see who is passed, who our new admissions are, and if there's been any like new changes. A lot of times the nurses will let me know, hey, this person's caregiver is asking for you to reach out to them. They've got questions about this. And so then I'll reach out to them. And if needed, I'll go out, do a face-to-face with them. Now, Medicare requires a social worker to complete an initial psychosocial assessment within the first 5 days of admission. So I go out and I'm addressing or assessing their readiness for hospice, their coping, orientation, just kind of looking at what their care support is. And if they do have a care support, what is that caregiver support system? Because what we see a lot is caregiver burnout really fast.
Real fast.
And I will say hospice in each state is a little different. So, like, some states actually have hospice houses where your loved one goes, they get admitted, and their hospice care is provided in that facility. Virginia is not one of those states. So we are providing the care essentially wherever the individual is, whether it's in their home, their family member's home, a nursing facility, homeless shelter, motel. Mm-hmm. Essentially, we're going wherever that they're at and ensuring that they've got everything they need to be comfortable.
And the only thing, so we've taken care of patients in motels. Also, we've taken care of patients that are homeless, but there's a caveat with that. They have to be they have to be at the shelter a designated time. They just can't like, yeah, I'm going to be there. No, if we're going to come to you, then this is what we require, and then it has to be, of course, be a safe environment. So that's where Crissy would come in again and kind of assess the situation and make sure whoever's running that shelter, like we're all on the same page. So it's available to anyone. It's just a matter of knowing about it and then going back to what my job is. My job is to help paint that picture so the patient can get qualified.
Right.
And so it's, my job to go out and get records and just kind of do the back office stuff, so to speak.
Right. When you're dealing with hospice, we know there's what I'll call a cutoff, so to speak, because the person's not going to be here forever. And so when the person expires, it's hard for the families, and maybe it's hard for you too, because you're human, and maybe on some level, I don't know, you pick up the emotions of what family members are going through. So how would you decompress? You'd form a relationship with somebody, and then the person is no longer here, and you form a relationship with that family, and then you see them, going through various stages of grief. So how do you separate yourself, if you can, at the end of the day?
Yeah, no, that's a really good question because there is a lot of countertransference of emotions and energies. And I will say, from my own personal experience, I've always been the type of people pleaser. I've always tried to focus on fixing things. And hospice has been the one area of social work I've worked in where I can't fix that they're passing. But what I can do is ensure that their quality of life and their autonomy is respected. And just knowing that sometimes gives me a little bit of a relief. There are a lot of very high stress moments, a lot of complex emotions that I do deal with, especially when the family member's in crisis or the individual passed a lot sooner than expected. And it does take a big emotional toll. So I have to take care of myself first. So a lot of times, like I do yoga, I try to get a good amount of sleep because my biggest thing is when I'm stressed, I stop sleeping. It somehow gives me insomnia. So yeah, I make sure that I'm taking care of my body because if I'm starting to dysregulate, then I can't be there to help the family members processing their own issues or needs. I also have my own therapist, which has been very beneficial. I think a lot of people don't think that social workers need one, but really we do because our line of work is to focus on helping individuals navigate their own needs and problems. And sometimes because of that, we're so focused on it, we don't take care of ourselves. So it's important that we prioritize our needs as well. And seeing our own therapist definitely helps with that.
This is almost a 24/7
Yes.
job. Do you get much time off for yourself?
Yes. So for myself, so hospice is available 24/7. As a social worker, I am actually only available Monday through Friday during normal business hours. So I do have that boundary where I can cut off work at 5 p.m. and say, all right, I'm not going to do anything until I go into work tomorrow. But then during that time I'm off, I have to make sure I'm doing things for myself. The nurses as well. The nurses are the ones that are really available 24/7 because a lot of what hospice does is managing the dying process and the physical symptoms associated with it. But thankfully, I don't have to worry about finding time in my own schedule for myself. It's just more so a matter of making sure I'm putting that into action because I do have some time available to myself.
Right. So is there a lot of turnover as far as the work that you do?
So this is a high burnout field of work. The nurses tend to have a higher rate of burnout. Of course, social work does as well, but what I've learned in my experience is having to set those boundaries 1st. When I'm working with a patient and their family, I'm assessing and having to separate a lot of the emotion from what the main objective is. And so when I'm providing the family with support and resources, a lot of times there's a lot of high emotions, and the family can expect the social worker to do everything for them. Whereas in some circumstances, like if the individual had no family, I would then be working with that patient to make sure all of those needs are being addressed. But if the individual has a family support system, I'm focusing on empowering that family and giving them the tools they need to do to help their loved one. And that sometimes can be very misconstrued, especially being a social worker. So having to set those hard boundaries and say, no, I can't do this, but what I can do is provide you with these resources so you can make the best decision for yourself or your loved one.
And is this field of hospice care and social work more dominated by women than men?
Yes.
Yes. Yes. Generally, every field of social work is high population of women. But medical social work is definitely high women. And of course, working in hospice in general, it is very women dominant as well. We have a female medical director. All of our nurses are females. We have the only male on the team is our director of operations and our executive director.
So we have, it seems to me that with the hospice though, also, there are men that are more the chaplains. So I found that. So that's probably,
Our chaplain is a male.
yeah, 50-50. And we have most of our chaplains for Affinity are male. No other reason than that's just how it is. Majority of the nurses are female, and then directors, probably majority are female. But the males that are in the field, they're just, they're a rare breed. Like I call my boss the unicorn. I because I mean, it takes a special person to do, he runs the whole state of Virginia, and he gets it. Like he has his master's in social work and hospice social work. So he gets it. So he is all about the patient and the family. And he gives me full reign as far as what I dictate to everyone to make sure that that's taken care of.
Right. So if a patient is in the hospital, so to speak, at what point do you think the doctor or the nurse says it's time to go into hospice?
I would say typically it's once they've done everything possible. They've done every possible treatment, it's not working, or they've gotten to a point in the disease process where the only option that is available is keeping them comfortable. So then that's when that doctor would have that conversation with that family and then reach out to us. And Kim would go out, or one of our nurses would go out and do a consult and give them a little bit more education before they make that okay.
And a lot of times the doctors do not want to have the conversation because they're healers, right? They're in the hospital, they're trying to heal. So it's very important for the hospice agency that's in the area, the local area, to build that rapport quickly. And the reason for that is so we can take care of the patient and get them what they need sooner. Because doctors just, they want to heal. That's their goal. So they don't always see that there's another option. Instead of just continuing on with chemo, instead of continuing the cycle, right? The cycle. So that's where like someone like me comes in and just go into the hospital, educating, talking to the hospitalist, I'm talking to everyone. And then they slowly are like, hey, you know what? We're going to give Affinity a call because we think this patient's family might need a little bit more. So that's kind of where we come in. And then having a good team to be able to refer the hospital to is imperative. They can call us all day long, but we want to make sure that they're taken care of.
Right.
And there's always a sense of urgency too. As soon as we get a phone call, it's not like home health where, yeah, well, we'll get in touch with them. As soon as we get the phone call and somebody needs, whether it's palliative or hospice, there's a sense of urgency.
Yeah.
We want to, they're in crises, whether they know it or not, they're in crises. And this is where we come in and we kind of like manage the crisis. And a lot of the hospitals are starting to realize that it's imperative to partner with palliative and hospice.
Okay. And so hospice is really more like comfort care than just keeping the patient comfortable.
Yes, ma'am.
Palliative is a very broad umbrella, and hospice falls under that. Palliative is comfort, that care that you can receive while you're receiving treatment. So let's say like you've got a terminal illness, the doctor has recommended, but you're like, I don't think I'm quite ready for
Ending
hospice.
or ending chemo.
Or yeah, or I want to go through everything first to see if it helps. And during that, palliative can come in and provide that pain management and comfort and all of that. Once it gets to a point where there is no treatment, the treatment's not working, or there's a bad reaction to the treatment, or there's no other options, they've gone through them all, then that's when hospice would come in, because we're looking at not just, no treatment no longer being available, but making sure that during that time period that they are alive, that they're receiving comfort, dignity, and their wishes are being respected.
Have you ever seen someone go into hospice and then come out for a while and then go back in?
Yes, that happens. So we call it graduate, like they graduate from hospice, and it's a good thing. The majority of the time when we step in and that person's finally getting extra care, meaning like having the nurse come out, having an aide, having a social worker, just having more support, we find that the patients actually perk up. They're finally getting some good, they're finally getting some one-on-one and they're getting some care. And then we see patients where they graduate and they come back. Like we want them to graduate and then they'll come back. You don't have to, once you're in hospice care, the one thing is that if you're not ready, then you can always call revocate. You can always say, you know what, I'm feeling better. I don't think I'm there yet. Then you revocate. You have the say. The patient and the family have the say. But and it's a wonderful thing because it'd be great if they could all graduate. But unfortunately, that's not always the case. How Crissy and I got together was we have a mutual friend, the one I was telling you about that's 107 now.
Yes.
Yes. Well, we took care of her daughter that was 86. And she graduated, but then came back on. And so then we've always stayed in touch with her name's Virginia because she was by bereaved. And then Crissy was her social worker. And I tell you what, she should have been on hospice a long time ago. We got her on hospice, and then now she's doing great because she finally has some one-on-one care. We have our aides going in. She's loving it, but she's 107. So at 107, if you want to stay on hospice and have your aide come out and hang out with you for a couple hours, then you can have it. At that point,
we just the big thing with hospice is you have to show that there's some type of decline or need for continued services. So your first two benefit periods, so the first benefit period is 90 days and the second benefit period is 90 days. Once you've hit that 6-month mark, if you're still with us, then we're reevaluating your eligibility every month because insurance is looking at it as, okay, well, do they still really need this benefit? Because they have lived past the life expectancy for that terminal illness. And sometimes that happens. And we've had personally, I've had some experiences where the individual were like, we know that they are benefiting from the service, but they no longer meet that criteria. So we have to discharge. And then either not long after we discharge them, they decline and pass, or they end up coming back to us. So
it's not a hard, fast rule.
But the insurance part behind it can sometimes make it very challenging because we see the need, but can we articulate the need to the payer source?
So most of the people who you've worked with who are in hospice, are they mainly elderly people, seeing that the population's aging, I want to say aging in place,
Yeah.
and people living longer lives.
Yeah. Medicare is probably our primary for our hospice patients.
We do have some on Medicaid or they're dual members, so they have both Medicare and Medicaid.
With VA.
Yeah, we have individuals that are a lot of veterans going through their VA benefits.
Seeing a lot of that.
So insurance will cover this, but the person has to have insurance like Medicare or so to qualify.
Yes, some agencies, so it depends on the hospice, but some agencies will take on what they call a charity patient. And so they will go through, do a resource assessment, and then they will out of their pocket pay for the individual's needs until they pass. And then they'll kind of eat the bill on that one, but it's because that individual is in need.
It's the right thing to do. So, I mean, I've gotten phone calls from family members and they don't have anything. There's nothing. So we have Affinity has a process for charity cases. And so then we present it, and there's also well, I don't know, I wouldn't say most, but I know Affinity, and then as well as Riverside, we had a hospice foundation, which the foundation takes care of. So say a patient needs a AC unit, things like that. Yeah. So with the charities,
they need money for burial, things of that sort.
right.
We take any donations that come in and put it in that pot of money, and then that pot of money is designated for helping anybody in need.
And they don't have to have that, but that's just something that Affinity has. And then Riverside had the same thing. And it's wonderful because it's nice to be able to say, our nurses will come back and say, this patient's living, it's 100 degrees outside, they don't have an AC unit. And we can present it to the foundation and say, hey, we need an AC unit for such and such. So that's a wonderful thing, that it's nice to be able to have that tool and be able to offer that if we need to.
Right. Seeing that AI is a thing now, are you using that at all in your processes?
We actually do. So the nurses, and I don't know the name of the program, and I could certainly find that out for you, but the nurses, when they go out and do their assessment with their patients, so they go out and they say, see Mrs. Smith, and they put everything that's going on with Mrs. Smith into their system. And then that system takes a look at and say, okay, based on all these symptoms, it looks like this patient might be a level 2. We're talking about the different levels. Level 2, and that means needing more visits. Also, it kind of helps with the newer nurses when they're not real sure about like what they're seeing, how that all relates. They put it into this computer program and it will tell them, like, hey, based on what you've told us about the blood pressure, the respiratory, all these other things, this patient is actually at a level 3. That's where the AI, that's where that comes in.
And there are how many levels?
So there's different levels. So you start out with, say, the nurse starts out and the patient's not bedbound. It's all clinically determined. So that could be like level 1, where they're up and about, they're doing their thing, and they need a nurse once a week, and then they need an aide maybe once a week. And then as their need gets greater, the level goes up. So it can be 1 to 4, depends on how the agency has their
So basically,
has their steps.
What it does is it reads the data, and based off of research and comparing the symptoms to other individuals that have been in different parts of the dying process, it'll suggest, hey, you need to increase the visits because this individual's their symptoms that you're documenting are indicative of this possible stage of the dying process.
It's a suggestion, and it works great because the nurses are out there doing double time, and so it's always nice to be like having it kind of double checks, like, I'm putting this in and I'm not real sure. Let's see, compared to someone else at this stage, like, should I increase my visits? How, and it's just a really nice tool. Okay. And then the clinical director kind of directs them the right way. It's not hard and fast, but it's definitely a nice tool for them to have.
Also, why is death so scary to people? Why is it hard for people to talk about this subject?
Honestly, I think it's a big society kind of view on death, that it's sad and scary and morbid, and it can be. And each culture looks at it differently. So everybody mourns differently, whether you're Muslim, Jewish, Asian, a lot of, yeah, atheists. I've seen quite a variety or a diverse amount of culture working in hospice. And I think a lot of it has to do with just the stigma that's kind of associated with it.
And I think
And it's hard having to face those emotions because no matter how accepting you are of what's going on or aware and I'm okay with hospice, it doesn't stop you from feeling those emotions. So you can be accepting but still be going through all the stages of grief. And a lot of times a lot of people don't want to feel that.
they don't want to face their own immortality. I get that a lot. And going back to talking to providers, they don't really want to, they get like 2 days in med school on end of life care. That's it. So, I mean, that's not what they're there for. They're there to heal. They don't like to have that conversation. And it's kind of like facing death yourself. We're all going to die. And sometimes it's hard to face the fact. So I run into that a lot too.
Is there anything else that you'd like to add?
We could go into every aspect of it. I think we just kind of like tip of the iceberg.
So it's very rare in my own experience where we've had somebody come in the beginning stages where they're kind of like Kim said at that level one where they're still able to do things for themselves and want to be independent, but there is nothing else other than comfort care available at that time. It's very rare because most of the time what we get them is they're kind of already in that transitioning process. They've declined even more from where they were. And now here we are, we may have them for 2 weeks to maybe a few days or maybe even a month. Like it's very short. So like, for example, I can count on one hand the amount of people that we've had that have kind of started early and transitioned and toward that 6 month, that was when they passed. And a lot of times what I heard from the families was that they were like, we had a really hard time accepting this at the time, but we knew that this is what our loved one wanted. And we're so glad we did it because the support that you guys provided us helped us process our own grief, or it took away some of the stress so that they could then focus on themselves and make sure that they're being taken care of.
Right.
And starting it early, it's scary, but it can be more beneficial in the long term. Whereas coming in like last minute, a lot of times we end up seeing families grieving the hardest, or they're just in complete shock, still trying to process. Like they were literally walking a week ago, and here they are, they've passed within 1 week of coming home and being admitted to hospice.
And that's what we were talking about, Candace, that I just wish people would use our services sooner rather than later or when they're in crises, because having us come in sooner, I've never had a family say, I wish I never would have called hospice. Every family that I dealt with when I was dealing with the bereavement part, they were just like, I wish we would have known. I wish we would have called sooner. I wish my doctor would have told me. I wish somebody would have told me. Like, because, well, as you know, with just like with your mom, if you would have known that there were this service that you could provide her while she was at home, it would have been, I just think, so much better. Her quality would have been so much better. Should have been surrounded by her things and you all instead of in these facilities. So that's, yeah.
And I do a lot of advocating for the patient specifically, making sure that their wishes are being followed. There do come times where, let's say, their wishes to pass in their home, but the caregiver is like, I can't do this anymore. I'm burnt out, and it's getting to a point where it's greater than what I can provide. So then we start having that conversation of long term care placement. But at the end of the day, like, or not at the end of the day, but before I even jump into that, I start looking at, okay, well, what caregiver supports are possibly available to keep them here
In the
a little
home.
bit longer, because we don't want to jump to the most restrictive. We want to make sure that the patient's wishes are being protected. And of course, we look at safety in the context too, but I personally try to go from least restrictive and see what other outside community resources are available to make that happen for that person.
And
Yep.
of course, it helps too to have an advanced directive to
Yeah.
to guide all of
Yeah.
that too.
And then just knowing where you can get help, like the VA, a lot of people don't know they have time and attendance where you can actually, if you're a veteran or even a veteran spouse, the VA will pay. They have a social worker that comes out and assesses the patient's needs. And then they'll say, okay, we'll pay for 80 hours a week of personal care. A lot of people don't even know that there's that benefit. Medicaid, of course, has that time and attendance as well. And then you can get an aid, even if it's 10 hours a week, that can help keep a person in their home. So that's all of our jobs. Our whole team is to get all the resources we can to help the patient to try to stay in the home if they can.
Well, this has been very informative and
That's a lot.
an important conversation to have, at least maybe
Yeah.
to give them more of an understanding and perhaps even a sense of closure.
Yep, and we can send you, I mean, if you want some additional information, like we'll be more than happy to send you. I mean, we've got just a ton of resources. And we're always constantly reaching out to the community and finding out like who can do what, those kinds of things. And it's nice for the families where they just make one phone call and they can call a hospice agency because 9 times out of 10, they're going to know. So, yeah. Anything else?
Well, I appreciate your time. So thanks to both of you for this conversation and today, and let us definitely stay in touch. Thank you very, very much.
You're welcome.
Thanks,
All right.
you.
Have a good
Take
afternoon.
care.
You too. Thank you. Bye-bye.
Bye bye.
Bye-bye.